Good afternoon, everyone. The case is entitled Double Trouble Bifurcation Lesion at the Distal Cap. Clinical data, he's a male patient, 64 years old. He's hypertensive, dyslipidemic, and he is an ex-smoker. He underwent PCI to LED in 2014, and he had a failed attempt of PCI to CTO RCA in 2015. And he was complaining of angina class 3. This is his angiogram. With, you can appreciate here as a long CTO segment of the RCA. The collateral swelling, there is an ipsilateral collateral from the RV branch epicardial to the PDA, and there is a septal collaterals as well to the PDA also. On evaluating the lesion, we have an ambiguous proximal cap. We have a bifurcation at the CTO exit point. We have an intervention collateral septal and a very tortuous ipsilateral one, and a very long CTO segment, more than 20 millimeters. So we have a GCTO score of 4 points. The plan was to go for a retrograde strategy with a reverse cart, attempt the second septal. If failed, we're going to tackle the ipsilateral epicardial collateral, and this is going to be challenging with a careful dissection re-entry to preserve the integrity of the bifurcation. And we plan to use a double human microcatheter if the side branch was compromised, and we adopted a provisional stenting strategy. Corsair and the wire sewn to the PDA and exchanged with the Fielder XT. The Fielder XT was managed to enter the CTO body, then do the knuckle to preserve the PL branch, and trials for re-entry. You can appreciate here the wires are not over each other. Tried to do draft. Of course, this is not the optimum site to do re-entry. And finally, guideliner assisted reverse cord was done. And RJ3 was externalized, and at this stage, the PL branch was compromised. So we need to wire the PL. A double human enhancer microcatheter was used, and the PL was wired successfully through the antigrade approach. 3 overlapping stents were deployed across the RCA. However, we had a dissection at the PL branch, and the patient had severe chest pain and bradycardia. This is the atropine effect. You can appreciate a dissection here. So PL was stented, tap technique, and this is the final result. And we checked the septal, they were fine. Total procedure time was 195 minutes, radiation dose was 4.2, and contrast volume was 300 cc. These are the equipments used. Distal cap bifurcation lesion is a challenge, and if a short lesion is present and true-to-true strategy is more likely, we can do antigrade wire escalation into both branches, or antigrade wire escalation into one branch and antigrade dissection re-entry to the other, or antigrade wire escalation into one branch and retrograde into the other one. And if it is a long lesion with more likely to do a dissection re-entry, retrograde dissection re-entry is the safest option, or retrograde dissection re-entry and antigrade dissection re-entry into side branch if compromised and failed antigrade wiring, or double retrograde or double antigrade dissection re-entry. Thank you very much.
thank you. It's a good case. Dr. Garratt and Dr. Parikh is here, so they will take over for moderating the sessions. And please be reminded that we are supposed to, you did good, we started 3 minutes late, but just to remind that we are using 5 to 7 minutes so that we have 3 minutes to discuss.
Spectacular case, very difficult, and a lot of good technical wizardry there that managed to get you through. I think you always have to be a little sanguine about the radiation exposure at the time of the case. You did a nice job with containing the contrast volume. That could easily have been a 400 or 500 cc case. But 4 grays or more, you have to really be mindful about that. And I like the fact that you rolled your camera around not only to facilitate good visualization of the target lesion, but remembering also that helps minimize risk of radiation injury to one particular part of the skin. And one thing I do think we don't do enough of in these complex cases, CTOs and otherwise, is shutter in the image. Once you've seen the field of play in your diagnostic studies and you have a good idea of what you're after, remember to collimate down and minimize the exposure of X-ray here, particularly when you see a long case coming like this.
Thank you.
Yeah, I think, so again, this is a prime example of long distal capita bifurcation. This is where, what we used to do in the early days of antegrade wire escalation or knuckling wouldn't work. And you saw then when you lost the RPL how sick the patient got. And so you really want to preserve branches. The other thing about the right coronary, you cannot knock off RV branches. We have, over the last 4 years, done about 1,200 CTOs, and every time we've gotten into trouble, it's been with right ventricular function and either hematomas or RV branch, loss of RV branches. So as much as we kind of take them for granted, you can't in these cases. And I think this is the way to prevent losing branches, because if you do anything with wire escalation subintimally, that's what tends to happen in the right coronary. So I think very nice case, well done, and all the tips and tricks that are necessary were utilized. Congratulations.
Thank you.
Shall we go on to the next? Great. Thank you very much.
Thank you.